Okay, so next we're going to talk about diverticulitis. I think you'll find it fairly light because there's not that many papers in it. It's on page 101 in your syllabus. It's one of those things that I think Rick was like, geez, we haven't talked about diverticulitis in 20 years, ever. But it's something that because it's becoming more and more common, because it's something that occurs with age, with increasing frequency, that we probably ought to talk about. But then when he went to do the search of the database, there wasn't a lot coming up. There's only 3 papers in here. And the other thing that I usually do in these talks is I find the papers that I think are really remarkable, things that you'd want to sort of have reference to so you could show them to a consultant or that you could have it in your own reference of important papers. And nothing really of these 3 abstracts here reaches that level. But if you were going to pull one paper in here, I'll tell you which one it would be. There's a consensus guidelines from the American College of Colon and Rectal Surgeons, and that is, let me see, it's on page 105, and it's the paper there by Rafi. I'm just going to find, it's in the second paragraph from the bottom. No, hang on, no, it's not that one. Anyway, I'll point it out to you when I get there. It's by Rafferty, and it's not, maybe it's on the first page. Anyway, when we get there, we'll get there, and we'll talk about it. And that's the one paper that if you're going to, now I'm frustrated, I want to find the darn thing. Has anyone found it, where the reference is? It's in one of those texts, it's in the text section. 103 and third paragraph? Yeah, that's right. It's on 103 under what laboratory and imaging studies are indicated. There's a little section there, it says Rafferty, diseases of the colon rectum. That's the one paper. I would just circle that and put a star beside it. If that's a paper that you might want to take home from this talk. Okay, so now let's talk about diverticulitis a little bit. I'm going to give you a little bit of an introduction and talk about, this is actually an interesting thing because we have PAs and NPs at our place, and it's remarkable when you start they know how to do everything, order all the right tests and do all the things sort of mechanically, and in this case the CT is often involved. But when you actually start talking about the pathophysiology, it's remarkable to see sometimes how they don't really understand the pathophysiology of different things. And when I'm trying to explain it to them, for gallbladder disease or for diverticulitis, it's remarkable how often as I'm explaining it, I'm thinking that I don't really understand the pathophysiology as I'm trying to go through. That's why it's good to teach, because it sort of shows up your knowledge deficits. Anyway, a few things about the pathophys of diverticulitis. First of all, it's from outpouchings in the colon. All right, we all know that. At the site of the vasa recta, where the perforating vessels go through. And as I think most of us know, it's uncommon in the developing world. They don't have much of this in, for example, India. They don't have a lot of diverticulitis. And that's led to the widespread belief, like we all tell our patients, that it's due to diet. But the other thing that's kind of interesting that I learned actually for the first time, I think, when I was reviewing this literature, it was just something that I had suspected, but it's actually a fact that Asians have right-sided diverticulitis commonly, and non-Asians, all the rest of us, have left-sided diverticulitis. And that's really weird. And that doesn't actually change depending on where people live. That appears to be a genetic thing. So if you look at North American Asians, they still get a preponderance of right-sided diverticulitis. Did you guys know that? No. It's kind of, yeah, well, apparently it pans out. And when you look at the case series, that's what the data shows. We all know that it goes up with age. That's another element. And then just to talk about the clinical course, what I'm doing is you can see there's a lot of text there, and I'm sort of summarizing all that text. In terms of the clinical course, diverticulitis is something, diverticular disease, the outpouchings that we get, are so common that by the time we are 80 years old, 70% of us will have it. If we do a barium enema or some sort of study that shows the contours of the lumen, you'll see that there's outpouchings in 70% of us. Only about a fifth of us are thought to get any types of symptoms from this disease in the course of our lifetime. And most of the time, it's something that's kind of like an irritable bowel syndrome. It's very much indistinguishable from irritable bowel. And so you see this all the time in the emergency department. You see nonspecific abdominal pain as a diagnosis. Some of those are due to diverticular disease, we think. And it may be very difficult to distinguish them from irritable bowel disease. And what do you tell those people? You tell them to follow up in 24 hours, abdominal pain check. You tell them to change their diet. Do you do that? Well, you might tell them to take a high-fiber diet. Is there any evidence for that? There is evidence, and there's 3 papers that are quoted there. None of them are in the database, but they're all down there on that first page. And there is evidence that a high-fiber diet might be helpful for those people. So it's really family practice stuff as opposed to emergency medicine stuff, but it's something that there is some evidence to support. There's also some evidence to support that using 5-ASA is helpful for those people. That's not something I would usually prescribe from the ER. I would usually just tell them to do the high-fiber diet. And the other thing that might be interesting to you is that there is an antibiotic treatment that is proven effective, at least in 3 studies, on long-term basis. And that antibiotic is called rifaximin, which I've never used. Okay, and that is an antibiotic that's not absorbed in the lumen, so it just decreases bacteria. It's not absorbed through the lumen, so it just decreases bacterial counts in the colon, and those people do better. So the evidence there is for high-fiber diet, for 5-ASA, like Asacol, or for antibiotics. What there is not evidence for is antispasmodics. So that's something that would surprise a lot of people, I think. There's one thing I think that's important for ER doctors, and especially ER doctors in places that practice, like in places like where Diane and I practice. We practice at big county hospitals in Los Angeles, where a lot of our patients receive their entire care from our emergency department. They never sometimes make it to an outpatient setting, and that is that there's a recognized risk of cancer. And so when people are coming in for visit after visit, maybe they've had 10 visits over the course of a few years for abdominal pain. At one point they're discovered to have diverticula, maybe they've had a study. It's incumbent upon us to tell them to get colonoscopy. So that's something that might prevent, and there's a lot of lawsuits about that. There's a lot of lawsuits where people get colon cancer, they look back in their chart saying, look, the patient been coming to you for 5 years and they've been having nonspecific abdominal complaints. There is a documented increased incidence of colon cancer in people with diverticular disease. So you should have told that person they should have colonoscopy. So it's just something to think about to add to our dispo instructions, especially for patients who don't have a primary care doctor that's on top of these things, to tell them, hey, you should probably get screened. So that's all sort of, I would say, family practice sort of stuff. I'm a family doctor, by the way. I did family practice actually not far from, if you go down across the border to British Columbia to Fort St. John and Fort St. James, there's a whole bunch of places not far from Alaska. That's one of the things I did before I got into emergency medicine. So I have a bit of that family practice perspective that keeps sort of sneaking into my thinking. Okay, let's see what's next. The next section here is about atypical presentations. And again, this is not something that's really where we're combing through the evidence. We're just reminding ourselves of things that we have to keep in mind when we're treating people. There are 3 groups of patients who might have minimal tenderness on exam, for which you might want to go a little further when you're thinking about the diagnosis of diverticulitis. And those are immune-compromised people, people with AIDS who might have less sensitivity, elderly people whose worn-out older pain fibers might be less able to transmit pain and tenderness, and pregnant people. And pregnant women have a stretching of their peritoneum, and that causes them to be less sensate, so they're less likely to develop peritoneal signs. So those 3 groups of people, even though you might not have peritoneal signs, if they say that they're hurting, then you probably should go forward with a workup on those people. We talked about right-sided diverticulitis. That's probably not a huge problem, because if someone comes in with right lower quadrant pain and you're thinking about the diagnosis of appendicitis, you're going to be following that up with studies and you're going to be onto it anyway. I guess it could be a bit of a problem if someone comes in with right lower quadrant tenderness and they've got an appy scar there, and you're like, well, I don't need to worry about this person, right? They have an appy, and you sort of dismiss the tenderness that they have there, and there's something that has to be non-surgical. So if someone has an appendix out and they're Asian, especially, consider the diagnosis of right-sided diverticulitis. And then there's another group of patients in terms of atypical presentations, which are people where they're so sick that you would never know that it's an abdominal problem in the first place. So someone comes in dying, septic shock, and you have to figure out that they have a perforated diverticulum and a big abscess, that type of thing, because they're not saying anything. They're too sick by that point. So those are the 3 atypical presentations. Okay, so I want everyone to turn to page 103 now. Is there any questions about that stuff? I just thought it would be good to go through a little bit of a review of that stuff. One other thing I should probably mention is that bleeding is not something that's seen with diverticulitis. So acute diverticulitis, when the outpouchings actually get infected, okay, and there's thought to be some sort of microperforation around the area where there's inflammation. It's a microperforation. It's not necessarily a surgical thing. Those people develop a fever and a leukocytosis and left lower quadrant pain. They don't typically have bleeding. So if you do a rectal on that person, and then you see, you've got a maroon-colored finger when you after your rectal exam, where you see that they've actually passing bright red blood, the diverticular bleeding, which is the other complication of diverticulosis other than acute diverticulitis, they're not usually associated with one another. So you should probably think of other diagnoses, like things like Meckel's diverticulum or cancer, that type of thing. So acute diverticulitis and diverticular bleeding are usually sort of separate entities. On page 103, we get to the sort of meat of the matter for the emergency physicians, which is how do we stage and how do we treat the different types of diverticulitis. So right here we have a table that correlates with mortality called the Hinchey Classification. And this classification was the standard classification for years and years, for about 20 years, until CT started becoming more common and they started CTing people. And this modified scale is the new version that incorporates the CT findings. I think really the meat of the matter here is the stuff that Diane was talking about, which is, are we going to CT everyone? And that's what we're going to get to in a second. When we started CTing people with diverticular disease, and my experience was particularly jarring because I came from Canada, and in all these places that I'm talking about in British Columbia where I was working, we didn't have CT scanners. And I went from an environment where you wouldn't have really, diverticulitis was not a CT diagnosis, except that the patient was hypotensive and shocky. And in that case, it was just a surgical diagnosis. They didn't ever get a CT. But I suppose if we would have had one, we would have done it. But I went from that type of practice environment to one where I went back and did residency in the States, where my senior residents were saying that I was reckless because I wanted to send people home with left lower quadrant tenderness and maybe a little bit of a fever and not image them. They're saying, you got to image these people. You got to do a CT on them. That's what we do here. That's how we do it. And so for me, it was a very jarring thing. I think probably the Canadians now, and you guys could let me know, probably do a lot more CTs than they used to. And it's a lot more available. But I still think the meat of the matter here is, do we have to CT all these people? So the people in the first two classes here, 0, 1A, they're considered mild, and there's not much debate about those. They can be managed conservatively. And we'll get down to the management, the conservative management in a minute. But they can be, treated as outpatients. They can be on fluids. They can have antibiotics. And there's not much controversy if you look at 3 and 4 fistula obstruction. The people that are very sick, there's not much controversy about them either. You're admitting them to an ICU setting. You're getting a surgical consult. And there's no real debate there. It's these people in the 1B and 2 groups, the people that have confined abscesses or abscesses elsewhere in the belly, maybe in the pelvis, related to the diverticulum. Those are the ones that there's a lot of controversy on. And the bottom line here is that we wouldn't necessarily, before CT, have dreamed that some of these patients that we just said, yeah, this looks really minor, they're just a little bit tender, send them home on Cipro and Flagyl. We wouldn't have imagined that some of those people had big abscesses and even distant abscesses. But the fact is they do. And the more you CT, the more you find out that these people actually have some pretty significant things. And so that's sort of what the issue is did you really need to do the CT to find that if most of these people got better anyway? So I want you to know that the summary of the evidence in this regard is 0. So the reason why there's so few, there's a few abstracts here that look at other things, but in terms of do we need to do a CT or do we not need to do a CT, there's no study that has people randomized to a CT or a non-CT approach, for example. So I can't inform you scientifically on that, but what I can do is I can give you a paper that justifies a management strategy that is less aggressive, that has less CT involved in it. And that's why I wanted you to circle that Rafferty paper. So that's in the middle of that page. What laboratory and imaging studies are indicated? In the absence of science, these colon and rectal surgeons, God bless them, because they've done something very nice for us, which is they said, in our opinion, you don't need to do a CT on all these people. They recommend doing a urinalysis, a CBC, and plain abdominal films. And I would do plain abdominal films in what situation? If A, I think there could be obstruction, right? That's one indication for plain abdominal films. And B, if you think they could have toxic megacolon. Did you say free air? So that's another possibility. But for that, in these cases, if you do an upright chest would be the most sensitive for free air, right? So you could do that, or you could do D-cubes. But in these cases, because they're so much lower, the processes, they often won't be positive. So, and because microperforations are associated with a small amount of air, they might not be positive. Sometimes CT shows it. So if you really have a concern about either obstruction or megacolon, and that would be an extremely sick patient that you're trying to sort of get a quick idea whether they got megacolon to get your surgeon, and you could do plain films. And then if you look into the second paragraph, you can see their wording, which is that the recommendations, we support a practice of selective imaging, and they flesh that in a little more detail in the paper, but they basically go through the same things that we're talking about now, which is that are you really doing anything to change management of these people? We don't think so, based on no evidence. So I'll take that. The other thing that they point out there, just as a reminder, is that studies that look at the lumen are not helpful if you're looking at an acute case. So, for example, a barium enema or colonoscopy doesn't really have a role in the acute management of diverticular disease. So if you think someone's, because the abscesses and the inflammation are outside the lumen. So it's either you're going to do a CT or you're not going to do anything if you're going to go further. There's a couple of studies there that are not really of great consequence, but the first abstract is basically just a study, it's a German study basically showing that CT is good. CT picks up a lot of things, and it's not really a scientific study, it's just observing that the CT shows most of the things that they think it's supposed to show. What's more interesting than that is sonography. So let's talk about that for a second. If you're thinking about a strategy to manage patients that doesn't involve radiation, and that's a big theme of this entire course, and Diane sort of kicked it off for us, but it's going to come up over and over again as we talk about head injury and all the different things that we're CTing like nuts now. You got to look at other things that might be helpful. So sonography is something that has been offered up in acute diverticulitis as an option to CT. And this study here, really not particularly scientific either, but it shows that it can be done, and this is a German study as well. They had, just to shortcut you to the conclusions, 51 out of 52 patients with acute diverticulitis, 98%, were correctly identified by graded compression ultrasonography. I think that's a little bit rosy in terms of what our averages would be at our places. The other thing is that if your place is like our place, they don't put a lot of emphasis on this. The billings for CT are higher. It's more convenient for the radiologist to get involved with a CT study than an ultrasound study, and they're not as good at it as they could be. Go ahead.
What are they looking for? What are the findings?
On an ultrasound, on a graded compression ultrasound, there's a sign called a target sign, where you see, and it's very similar to the appendicitis sign, where you basically see a concentric edema around a focus. And if it's right over the point, they're also saying where does it hurt, and they're going right over the point of tenderness, it's actually quite accurate. You might not see it because of overlying gas. There's all kinds of things that could interfere with it. It's not as accurate as CT, but this study shows that it can be done. What's more interesting than that is, can this study be worked into an overall strategy where people get ultrasounds instead of CTs and do well and are safe? Obviously, you take out the patients that are crashing that you're going to want a CT. If someone's, again, they're hypotensive, you think they've got a catastrophe going on, you're going to CT their belly. You're not going to, that's not the time to skimp on CT. But how about a strategy that just uses ultrasound instead of CT as a way of dealing with diverticulitis? And we do have a paradigm for that. That's in the third abstract there. There's only 3 abstracts, and that's the third one. And this is really exciting, and I've had a chance to see it myself. I got invited to Japan a couple of years ago, and I got a chance to see the way they deal with appendicitis and diverticulitis. They have a system where the person comes in and they triage them. The really sick people, they're just skimmed off the top. The surgeons deal with them. The patients that they're thinking possible API or possible diverticulitis, they put an ultrasound probe on. The ultrasound, they're very sophisticated with their ultrasound there. They've really honed it. And we could easily be like that too. The Germans and the Japanese have always been ahead of us in ultrasound and trauma and everything else. And in fact, they teach it to the surgeons, and it's on their board exams. They all have to do it, not just the radiologist. And in their strategy, the people that have right or left lower quadrant tenderness get an ultrasound. And there's ultrasound findings that are consistent with very bad appendicitis and very bad diverticulitis. It can look worse. And if they look really bad, they're referred to surgery. Not necessarily getting an operation, but the surgeons get involved and they see them, and they might do non-invasive approach. They might do a resection, but at least it's over in that surgical category. For the people that have the more minor grades of ultrasound diverticulitis or API, they just give them IV antibiotics or even PO antibiotics. So whereas we're used to people taking out people's appendices here, in Japan they treat them with antibiotics. Probably about 60 or 7% of them just get antibiotics. They go home, the inflammation goes away, they get better. Sometimes it recurs. And you guys have probably all know that although you're taught in medical school appendicitis doesn't recur, that it recurs. And the same thing happens with diverticulitis. But what they have there is a whole management strategy that avoids the CT. And the other thing they have in Japan, which is wonderful, is MR. And so sometimes when they come back, they do MR. So they actually have a whole setup there. I don't think they designed it. They didn't design this with the intention of cutting out CT, but what they've effectively done at a lot of centers in Japan is they've cut out the ionizing radiation from a lot of their workups. So that's really something neat. That study, Abstract 3, is not a scientific study showing that that management strategy is better than a CT management strategy or anything like that. It's nothing that scientific. It's just one of those papers saying, hey, listen, this is how we do it, and we think it works. No one died. and it's a reasonable way to approach a patient. So I think we ought to, it's food for thought. I think we ought to think about that. And what I'd like to see here in North America is a randomized control trial. Looking at an approach that cuts out the CT for the majority of people and compares it to the conventional one that we use now, which is CT the hell out of everyone. So that's that. Now, in terms of the remaining pieces of this talk, there's some words there about management, okay? So for the management of people that have the mild disease, that Rafferty article that I asked you to circle also has a permissive statement in there about you don't have to admit them. So in the patients that aren't toxic, that have tenderness there, that don't have any comorbid things like they don't have AIDS or they're not pregnant or they're not elderly, that kind of thing, or they don't have lupus, and those people you can send them home. And that paper gives you the permission to do it. So the reason why I want you to circle that paper is so that whenever you're pursuing a more liberal course, or would you call it conservative or liberal? Whenever you're sending people home and not CTing them, you've got a paper to say, hey, listen, this is what the colon and rectal surgeon experts say. Again, based on no science. So the antibiotics that you're going to use to treat them are listed there. I would recommend using the cheapest ones. Bactrim and Flagyl together would be a reasonable combination. I'm not so hot on some of these other things that are listed here, like using Zosyn. I don't know why we'd want to use Zosyn. It's a lot more expensive, and there's a lot more incidence of antibiotic-associated diarrhea with it. You can sort of substitute one nasty problem in your gut for another. So I think I would go with the simplest regimens there. You put them on bowel rest for a few days, you follow them up. If they're not getting better, then you can do imaging. You can do either ultrasound or CT after that. And I think that's a reasonable strategy. The other thing there on page 105, it talks about things that are really in the realm of the surgeon rather than the realm of the EP. But one of the things that I'm fond of teaching is that we really ought to know a little bit more about other people's business than they need to know about ours. So we need to know at least a step or two beyond what we're actually going to do with the patient, because it's going to help us in dealing with our consultants. If nothing else, it's going to make them realize that we understand their business so that they're more responsive to us. And so one of the big things that's in the surgical literature now is, do we need to do surgery on these people or not when they have an abscess? You guys all went through, at the same time, when we all went through our residency training, we were taught that anything that's an abscess has to be drained. And as you know, that's sort of being gradually whittled away upon, right? So a good example would be TOA, tubovarian abscess. What were we taught? We were taught the abscess has to be drained, right? It's a surgical issue. What do we know now? It's not true. If you give them antibiotics for 48 to 72 hours, these things shrink. And if you do a serial CT or ultrasound, you can see the abscess shrinking and they get better. You don't need to operate on a lot of these things. And so the current surgical thinking is that if the abscess, and this is based on some retrospective studies, that if the abscess is less than 4 centimeters, it's probably going to do okay with IV antibiotics in the hospital. If it's bigger than 4 centimeters, it probably won't resolve. It's kind of helpful information to know. So when you're doing this, when you are CTing that person for diverticulitis and you do see an abscess that's greater than 4 centimeters, it's helpful for you to know that they're probably not going to be managed conservatively. And that will probably change the way that you're going to behave and what you're going to say to your consultant. The other controversy is whether or not they should be operated on initially or whether they should be drained with CT guided aspiration. So if you've got, like, say, a big honking abscess, like an 8-centimeter abscess, what are you going to do with that patient? In our center, the inclination would be to put a needle in it and drain it. There's not a lot of good science that says that that's better than operating on them, but what the surgeons are telling us and what a lot of their papers say, just so you know what they're being told, is that if you drain the abscess first, if interventional radiology is the first step and not surgery, there's a greater chance that when they go in to do their operation, they'll be able to do a primary reanastomosis. And if they go in there on a big dirty scene and there hasn't been any pre-aspiration, what they say is that they're going to have to do a Hartmann, they're going to have to do a diverting colostomy. And the problem with diverting colostomies is that even though they intend to reverse them, right, If you have a patient who has a diverting colostomy, what do they tell them? They say, well, we're going to do this, and then after a few months, we're going to reverse it. But they never get them reversed because of scheduling problems, because they have other things wrong with them, like coronary artery disease and lung problems. For whatever reason, their surgical risk is a problem, and they don't get these things reversed. So it's much more pleasant from a lifestyle point of view for the patient if they can have it drained, if they can have a primary reanastomosis. And a lot of the surgeons think, with some evidence to support it, that aspiration will prevent them from having to do the complicated 2-step or 3-step procedures. So that's just another little tidbit. That's pretty much it. Wanted to finish a little bit early. I don't know if I'm early or late, but is there any... like a machine? Okay, we've got a couple questions. Let's do it.